Hi, everyone. My name is Terry Emerson. I am a nurse manager at the Johns Hopkins Hospital in Baltimore, Maryland, and I would like to speak to you as part of the ARN toolkit for the prevention of perioperative pressure injury. I will share with you what our ORs did and the process we put into place to help prevent perioperative pressure injuries. As we know, patients undergoing surgical procedures are definitely at risk for pressure injury. There's a variety of factors that contribute to this. Comorbidities, nutrition, age, ASA, BMI, position, and positioning aids. Pressure injuries cost about $9 to $11 billion in the United States, and averages about $20,000 to $150,000 per ulcer, and adds about $45,000 to the hospital stay. Pressure injuries are reported to some regulatory bodies. As we know, CMS for reimbursement will not reimburse any hospital-acquired pressure injury stage 3 or stage 4. The Health Services Cost Review Commission has we report to them as well, and they also look at reimbursement for any hospital-acquired pressure injury. The Agency for Healthcare and Research and Quality estimates there's about 17,000 lawsuits across the United States related strictly to pressure injuries that were hospital-acquired. So we wanted to take a look at it. Being a nurse manager of the neurosurgery service, we were finding that a lot of our patients in the prone position for spine surgeries were developing pressure injuries or skin integrity problems. So we really wanted to get to the meat of the problem and see, okay, why is this happening? What are the issues? And possibly how can we try to do our best to prevent them? So we had a focus group of our nurses and surgical techs. We really just sat down and we created this fishbone, and we looked at all the different variables that we felt went into the risk of pressure injury for all patients, but specifically what we looked at, as I said, was our spine patients in the prone position. So, things that you can't really control would be comorbidities, age, nutritional status. Some of the methods, which we refer to as positioning aids, are, foam, IV bags, pillows, gels. And Joint Commission has become very strict on anything that we do within the hospitals. As you all know, you really have to follow manufacturer's instructions for use. So IV bags are not used as positioning aids, neither are blankets or pillows. So we really needed to look and say, okay, if we can't use these, what else are we going to be able to use in place of the IV bags and blankets? We also found through the literature, foam, as we know as A-crate, really does not prevent injuries or pressure injuries. It really does not, that type of positioning aid does not disperse pressure or relieve pressure. The literature says it really is ineffective. So we needed to look at that because that has really become a sacred cow. We use A-crate pretty much for everything. We use the geomat, things like that. Then we looked at the machines. We looked at the Jackson table. We looked at the different OR tables. We looked at the Mayfield table adapters with your skull clamp and your horseshoes. We also then looked at Mother Nature, the procedure type, the procedure length, where the patient was going post-operatively. Was it a primary procedure or was it a revision? Because that would affect the time or length of the procedure. So we put everything down as the root cause. We made it very easy to look at some of the interventions that we wanted to put into place. So as we looked at man and we identified the risk factors, we really wanted to look to see if there was an appropriate and validated tool that could help us prior to surgery, preoperatively, to see if our patients were going to be at risk. We wanted to also educate our team members on, you know, reminders about skin assessment, how to assess your patient when you're in the pre-op area, how to assess your patient once you get into the OR. It's very important to document any pre-existing skin integrity issues, and that is because if you can prove, you know, that the patient had some type of alteration in their integrity prior to the OR, then it cannot be considered a hospital-acquired pressure injury, and that again helps with reimbursement. Some of the methods we talked about our positioning aids. So we wanted to eliminate the use of foam because it really is ineffective. So we had a positioning aid vendor fair, and we invited 5 or 6 vendors, wound care nurses, physicians, surgical techs, OR nurses, equipment specialists were all invited. And we created an evaluation tool. And from that evaluation tool, we chose one vendor so that we could really look at standardization and cost containment by just going with one vendor instead of multiple vendors. We collaborated with purchasing to get the best deal that we could. We did education for the care, cleaning, and use of the different positioning aids, and these are gel positioning aids we decided to go with. Gel positioning aids in the literature are better, of course, than the foam. They do disperse pressure more evenly when you use them as positioning aids, and they are reusable, they can be cleaned, they can be heated, they can be cooled, and so they are very flexible in their use. So we also encourage the use of foam dressings, Mepilex for the high-risk areas, especially for us with the spine on the chest, the groin area, the knees. That was very important for us. That's where we were seeing most of our pressure injuries. We did an in-service with our positioning and aids and equipment. We had the vendor come and talk to us about the different specialty tables that we were using. And then we also educated on, from Mother Nature, you know, the knowledge of the procedure. We also wanted a RN to RN face-to-face handoff so that you could look at the patient and talk to the preoperative status of the patient and then post-operative status of the patient. Then we identified a risk assessment, and then of course we still wanted to manage your comorbidities and hemodynamic status, and we also wanted to continue using the skip measures. Our measurement system was looking really truly at hospital-acquired pressure injuries, or HAPIs, that were attributed to the operating room. So what we did with our education was also, not only did we do the presentations, but we also created visual aids to help remind our team members what they needed to do to protect our patients and to decrease the risk for pressure injuries. So we created this this little poster here that we've put in all of our ORs. Talks about pre-op, intra-op, and post-op skin assessment and documentation, the handoff, the risk assessment, the using the appropriate transfer devices, and having enough support, minimum of 4, and that is you can find that in our AOR guidelines for safe patient handling. The PNDS documentation, so that we're all using the same verbiage, and then the gel positioning aids and to pad vulnerable anatomy. And then we also looked at transferring the patient to and from the OR table to initiate a safe skin scan, which I'll explain a little bit later in this presentation. So we wanted to assess the skin integrity, we wanted to document, and if needed, we wanted to place an electronic adverse event report in whatever system you may be using. We call ours at Hopkins a HERO. So you can see that we looked at the different positions and we listed the vulnerable anatomy and we showed where the vulnerable anatomy is on the patient, just as a visual to help out. So a little bit about our risk assessment. So we really looked at the literature and we really wanted to know, how can we identify our patients that are going to be at risk, especially because our cases are very long. They tend to be very complicated, and our patient population seems to have a variety of comorbidities. So we looked at the different tools that were available for pre-op um, um, risk assessment. We found Scott triggers, and we looked at this with the entire nursing team, and we really felt this was very easy, very appropriate for us. So we actually tried a paper pilot with the Scott trigger risk assessment, and we really found that we were gaining some traction, and we were able to have something to support our assessment so that we can alter our interventions in the operating room and provide the best care that we could do based on what the results of the risk assessment were. So Scott Triggers, created by Susie Scott, is very easy. It looks at just your age, it looks at your albumin level or your BMI, because not always do we have an albumin level. It looks at your ASA score, and it looks at surgery, the length of time of the surgical procedure. So I've gotten into contact with Susie, and I asked her if we could really look at taking her risk assessment and perhaps putting it into our electronic medical record. And she was, of course, very excited and very collaborative, and she was very supportive. So that's what we did. We worked with our electronic medical record team, and we put the Scott triggers information into our documentation, and in the background of the computer system, what it does is it pulls all of the information in to one screen. And if we assess that two or more of the requirements are met and the patient is a high risk for developing a pressure ulcer, we would see in our intra-op navigator, we would see Scott triggers, as you can see here in the square, would illuminate, and then you would be able to, the nurse would go over and attest that yes, the patient is 62 or older, no, the patient's BMI is not less than 19 or greater than 40, but yes, the ASA score is 4, and the surgery is going to be 6 hours. And then you can, so once you attest to that, then you could choose whatever whatever position your patient is going to be in for the surgical procedure. So if we utilize prone, then in our system, you are able to pull up a sidebar report that would list everything you saw on the poster, that would say, here's your vulnerable anatomy for this position, here's the recommended positioning aids, and here's, what you should do to intervene for your patient. So as you can see here, this is a little bit of the sidebar report that we use. So it'll tell you the positioning aids. It'll tell you what to look for. It'll tell you how to position. And then we have right now, what we said was a prone Scott triggers template for our positioning documentation. And what we have done is we've made this now as we have reassessed and revised some of our protocols, instead of just a prone template being that would come up for every patient, whether you're high risk or not, we have decided to put the prone Scott trigger template that will come up for every patient. Therefore, if you're going to do anything that deviates from using gel or deviates from what the position should be, then you would need to go in and alter that documentation. We felt this would be easier for the nurses, but it would also begin to generate, a more common way to care for the patient instead of having to change it from foam um, positioning on the arm boards, because as much as we want to get rid of the foam, it is still a sacred cow. It is still comfortable for the patients. So that has been slower process than everything else, but we are still working on it. And we have decreased the cost for ordering the egg crate. We have also taken it off of our DPCs, our doctor preference cards, so it doesn't come up automatically. We've also put gel positioning aids in all of our warmers within our ORs so that it's very easily accessible for the nurses. So I believe that has really helped to with the utilization of the gel. So as I mentioned, we do a safe skin assessment preoperatively and postoperatively. So what is that? Well, we know that in the pre-op area, when we are doing our interview with the patient, we can only see certain things in the patient. We might see their arms, maybe we could see their legs. Obviously, we see their face and their hands. But at that point, that wasn't really the best time to do an overall skin assessment because, you wanted to make sure that the patient felt comfortable. You didn't want to make them more anxious by, just doing that whole assessment there. So we thought, all right, well, once we get into the operating room, we have to transfer the patient from whatever device they're on, whether it be their bed or the stretcher, over to the OR table. And according to guidelines, we should always be using a transfer device to safely move that patient to and from the OR table. So what we looked at was a process in which when you put a patient onto the transfer device, whether it is a transfer board or whatever else you choose to use, you have to roll the patient. So as everyone rolls the patient, what we say is, okay, let's do a safe skin assessment. Now we're looking at the back of the patient. We're able just to, everybody looks, whoever's at the foot, whoever's at the head, whoever's on the side. We're all just real quick scanning the skin to see if there's any alterations in its integrity. And then post-operatively, we have to do the same thing, right? So when you're putting the patient on the transfer device, you can look at either the front or back, depending on the position. And then, once a patient is intubated and we start prepping the patient for the procedure, generally most of our patients don't have anything on them, depending on the procedure. So they are very exposed. So that's another way. If you're going to be prone, you've looked at the anterior part of the patient. So then when you put them prone, you can look posteriorly to see if there is any type of skin integrity issues. So we do that pre and post, and we make sure that we document it. It's very, as I mentioned earlier, it is extremely important to document any skin integrity concerns preoperatively, because if those concerns worsen during the procedure, we have documentation that they were there prior to. We in my OR, I have 14 ORs. We decided to see if we were making a difference. So we wanted to run and look at some of the statistics. So we did a study where we looked at a year's worth of pressure injury data from our wound care nurses, from any patients that had procedures completed on our OR, which is the Zayed 3 OR, and their post-op destination was any of the ICUs. So it could have been the surgical ICU, it could have been the Weinberg ICU, or it could have been the neurosurgical intensive care unit. And we looked at what those numbers were pre-intervention. So we did a retrospective study on that. Then we took September through October of, I think this was 2018 as our intervention time. And then we looked at December through, I believe it was, let me look here, October 18th through July of 19. And we looked at, okay, how have we done? Are we making a difference? And we worked with our Armstrong Institute for Safety and had them run the statistical analysis. And we found that, yes, we are seeing a statistically significant reduction in pressure injuries that are associated with the operating room in the post-op destinations of the different ICUs. And you can see here the number of pressure injuries decreased, and also the controls and the variation were actually much more tighter in the post-op phase, post-intervention. So now our plan moving forward is to be able to roll this out to all of the operating rooms and really get them on board. Unfortunately, COVID happened. So we are still working on that. That is our plan. And we are very excited with the improvements we have seen already. So with that, that is my presentation on what we have done at Johns Hopkins Hospital, but please understand and please feel free to go through the entire pressure or prevention of pressure injury toolkit through ARN, and please educate yourself. It's very important for us to be able to take the pressure off of our patients and make sure that we can provide the safest care that we can for them. Thank you very much. I hope you've enjoyed this presentation. And if you have any questions, feel free to reach out to me. I'll be happy to help. Thank you.